So, Ann, why don't you go first? Number one, and if that's helpful to you, I'm going to drop those lines down, or you can just do it off of your homework, whatever works.
So I had it as normal sinus rule.
Okay.
And then for infarct area, there's a septal and anterior.
Okay.
So that was V1, V2, V3, and V4.
So be very clear. So septal is what, anterior is what?
Septal V1, V2.
Okay.
V3, V4.
Okay. And is there any other evidence for those?
I had I didn't have, wait, hold on a second. I didn't have
Okay. Did anybody have any additional evidence? Yes.
I guess there are cues.
Yes, there are cues in V1 through V3.
Yeah.
Okay. And then let's see what else.
No signs of old infarction.
Okay. And now that you know, would you check for right-sided?
No.
Okay. And by the way, what's the rate on that rhythm?
Probably like it might be around 100.
Yeah, I think it's a little bit more. Yeah, I'd say if you use Box's method, 300, 150, it's on the high side. Yeah, so I think it's a little more accurate. It's not that big a deal, but sinus tach. So all that's really good. Did anybody else have anything in addition? Anybody else?
Where's depression in 2 and 3?
2 and 3. Okay, leads 2 and 3. Uh-huh. So okay, so here's mine. So the way that when I do these is I put things in parentheses, meaning it's okay if you have it, it's okay if you don't. Because many times on these 12 leads, there's some things that are a little ambiguous. So first of all, I agree with absolutely everything that Ann was saying, except for the sinus tach, but that doesn't matter so much. I also think you can make an argument for a lateral, and if you look and you say, wait a minute, I don't see one box of ST depression. Here's the deal. As Natalie, so first of all, if you don't put it, it's not wrong, right? That's what the parentheses mean, okay? Natalie mentioned there is ST depression in 3 AVF, maybe in 2. So we have depression in the inferior leads, okay? Are those reciprocal changes? Well, let's look at one in AVL. The problem with relying on one box of ST elevation is that's the standard. But when you have a QRS that's like 3 boxes, it has to be proportional. So in this, and there's also a few other things that we haven't talked about yet that I see, so that's not fair, that I see in one in AVL, sort of the shape of the shape of this is just very suspicious. So for that reason, and we're going to come back to this one when we get to our next lecture and we talk about, does the shape of that mean anything? Does that flip T wave mean anything at all? So as I said, I'm totally okay as long as you see septal anterior, but I have to mention there probably is something happening in the lateral leads, okay? And totally okay if you don't say anything there. Now, I only do this on one answer here, but how would you do it on the quiz? Because remember, you can't fill in there's no chart, so this is how you would do it. You would say septal, ST elevation, V1, V2, other evidence, cues, anterior, ST, V3, V4, other as evidence cues. That's wrong. I'm not sure why I said yes, I would check for right-sided MI. Totally wrong, okay? So I'll change that. Yeah.
I had a question about, it seemed like, the lateral leads, so one AVL,
Mhm.
V5 and V6.
Yep.
The QRS complexes all seem to be lower in amplitude in
Yep.
comparison to
Yep.
the other respective leads in those areas.
Mm-hmm.
Does that
Does
mean
that-
anything pathologically?
I don't quite know how to answer that. I don't think so.
Because, I mean, I was thinking,
Yeah.
if you're gonna have low amplitude like diffusely, I would think
Right.
of maybe like someone being obese or pericardial effusion, but like relative to the leads next to each
Yeah, I
one of
don't,
those,
I
they're
honestly,
pretty
I
small.
don't think so.
Okay.
Okay, I don't think so. And I'm leaving it like that. I'm sort of thinking, have I ever heard that? No, I've never heard that. But on the other hand, it's possible I've just never heard it. So,
Okay.
yeah, so I don't think so. Let me real quick change this so I don't forget. So no, I wouldn't check. Okay. Okay, so Kyle, do you want to do the next one? And I'll drop those down if that's helpful. Although here, gosh, we don't need lines. Okay.
So there's,
We did this one in class, didn't we?
did we?
Yeah, we did.
Sorry.
She did say not to write it down. What? She said not to write it down so you have an extra practice.
Oh, we did do this one in class, but go ahead.
There's lateral, so elevation in one AVL, V5, V6.
Okay.
Anterior with V3 and V4, and there's possibly some septal with V2, but there's nothing in V1.
Correct.
And there's reciprocal changes in the inferior leads,
And what does that relate to? What's that evidence for? Which,
the lateral.
okay, good.
And I don't see any pathological cues.
Okay.
For other evidence. What else can I put?
There's something you could add to the anterior, some evidence you could add to the anterior. Anybody know what it is?
Some cues, pathological cues. on the
No, they're not
anterior.
really big, they're not quite.
The hyperacute T wave?
Yeah, so, yeah, I would say,
I can't remember, was that based off of the J point or the
Yes,
isoelectric line?
yes. And so this one is probably, so we need, 2 large boxes. This one fits the bill and that one fits the bill,
Okay.
okay? And then rhythm,
What did I say then? I said that was normal sinus rhythm,
okay? And,
I would not check for right-sided.
okay, and any signs of old stuff?
Not that I could see, but
Yeah.
I could totally be missing.
Nah, you're good. Okay, anybody want to add anything, question anything, disagree with anything? Okay. So Riley, you're next, number 3. And I'll drop this down.
So there's SC elevation in 2-3 AVF,
Mhm.
inferior, and then I had anterior would be 5V6.
Okay.
Yes, and then I guess now, actually,
Wait, what is V5, V6? What area is that?
that is,
Not the anterior. What's V5, V6?
let's say, it's crazy.
Maybe I heard it wrong. What
No.
area is V5, V6?
Let's say lateral.
Good, okay. Okay,
Yes, and then what else did I put in there?
so do you have any further evidence in the inferior leads besides the ST elevation in 2-3 AVF?
I put, oh, hold on. I think I put reciprocal changes in AVL, but I don't think that's.
Yes.
Is that, okay, that is correct?
Just stop, that's good,
Okay.
okay? Okay, Anything else anybody wants to add for additional evidence? Yeah.
Does V4 have some elevation too?
Oh, how did I do that? I think, yeah, you know, that's one of those things that's sort of okay if you put, okay if you don't. Okay, so you could add interior for that. What was the rhythm, Ryan?
Let's see. I put normal sinus.
Good. And any signs of old stuff?
I actually am blanking on what the old stuff is. What's indicated?
So you're looking for pathological cues
Oh,
that
right.
are not
Right.
associated with anything acute, in a lead that has nothing acute about it.
Oh, in a lead that isn't acute.
Yeah.
Okay. Then, yeah, what I put in here is incorrect. But let's see, pathological cues. I didn't put any pathological
Good.
cues.
Okay, and then would you check for right-sided?
Yes.
Good. Anybody want to add anything?
I have a
Yeah.
question. The Q on 3, I said that was pathological because it's like,
Okay, that was one of the mistakes. That was one of the things I changed. So let me tell you what the issue is. And the problem is I've always sort of struggled with to teach this or not to teach it. And this year I'm teaching it. So it's one of those, 12 leads has all these funny little details, all these exceptions, things like, oh, ST elevation in V1 and nothing else, it's probably meaningless unless it's a right-sided, okay? Another one is Q waves in 3 and only in lead 3, okay? It's very particular to lead 3, are probably or could be normal variant, okay? You definitely see them.
those are going like all
yeah,
of
so-
question marks.
So the way I handle that piece of information, because it's sort of a confusing piece of information, is if I see Q waves, like big pathological Qs, in 2, 3, and AVF, then I count them. But if they're only in 3, then I just say, well, I don't really know. It could be a normal variant. Okay.
All the other ones, every single one I have them circled.
So Koa.
All right. Infarct area for 4, I had inferior ST elevation in lead 2, 3, and AVF, and then evidence for that was also ST depression and reciprocal changes in 1 and AVL.
Good.
Identified a rhythm, normal sinus. Are there any signs of old infarctions? No. Would you check for right-sided? They did, which is V4R in the top right.
Okay.
They suspected it because of the inferior STEMI, and there is a right ventricular MI. There is
Good.
ST elevation in V4R. And
Okay.
elevation in V1, which is an identifier for a right-sided
Good.
MI
Excellent.
as well.
Excellent.
And then slight V2 depression, which is also identifiable for our VMI.
Which, I'm sorry, what was that one? V2?
V2
Yeah, good, 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 good. Okay, yeah, excellent. Yes, please, Cody. Where's my pointer? Hard to say for sure, but if I look at these 3 and say which one is the most obvious, I'd say it's that one right there. Okay? Does that make sense?
Yeah.
Okay. Okay. Yeah, right there. Okay, so inferior, and again, the same issue with the Q in 3. It's just in 3, so it's probably a normal variant. This I didn't put in the lecture, so don't worry about it. If you want to remember it, that's fine. I'm not going to worry too much about it right now. If you have ST elevation, I'll explain it now, but I don't expect you to know, okay? If you have ST elevation in 3 and in 2, and if the ST elevation is greater in 3 than 2, then it's more likely to be right-sided. But don't worry about that. That's just one of those little details, hard to remember. Yeah.
So, yeah, kind of going off that, I wrote anterior, because the V3 raise ST.
So you call that, I'll go along with that. So where did you put ST elevation for the anterior?
On V3,
Okay, so if you have ST elevation in V3
it'd have to be in V4 as well.
or V2, you have to have contiguous leads. So is that elevation in V4? I don't think so. Though I think the way to ask yourself is, I could be persuaded, well, it's hard here to say for sure, but I could sort of be persuaded. But if you want to say there's an anterior STEMI, you have to be certain enough about it that if that was the only thing, you would go to the cath lab based on it. And I don't think you have it, because all you have is V3 and not really definitive in V4. I also agree with you, it doesn't look good. So this would be one that would be kind of interesting to do a second 12 lead down the road and look at those leads and say, has anything changed or gotten worse? Okay, number 5. Who's?
I said that, well, there isn't any ST elevation in any of the leads. It's normal sinus.
Okay.
And then I see some pathological cues. I'm thinking in V3 and maybe V4. I don't know if that's like a little far away from these S's.
Yeah.
So that might be.
Yeah, and would you check for right-sided?
No.
Yeah, I 100% agree with you. Meaning maybe anterior. This one actually looks like it, but then you see these little things
Right.
here. And in fact, if you put anterior there, I wouldn't mark that wrong because it's so hard to tell. And that is a very hard thing to tell. I remember the reference I got this from, I'm trying to think what word. It was something like a nubbin of an R wave, and they specifically call that, but boy, it's hard to see. So I'm okay, yes, I'm okay, no, yeah.
Does the lack of just the ROA progression to corneal
Yeah,
lesions
actually, that does mean something, we just don't know quite what it means, and it could mean an old anterior STEMI. It could be, but whether those are actual Q waves or S waves is really hard to tell, so. Okay, questions about this one? Yeah. Yes?
Was measuring the PR, is that close to a first degree or? Is that
Oh,
far?
let's see. I wouldn't put it, let's see.
Is it supposed to be 3 to 5 or longer than?
Yeah, greater than 5, so maybe it's kind of right on 4 to 5, so I don't think it's there.
Alright.
So, okay, who's next? Natalie, I think.
I said there's elevation in V1 and V2, so septal. There's also hyperacute T in V2 and a pathological Q in V1. And then I said anterior MI as well, and because of the elevation in V3, V4, and I didn't see any other evidence for that. And I said normal sinus rhythm. Now I'm looking at it, it might be 300. No, it's like on the cusp.
Okay.
And then I said I would not check for a right side.
Yeah, so I pretty much agreed with what you had here. Again, Q in V1 is like, maybe. Maybe inferior, old inferior. I wouldn't mark you wrong if you put it, I wouldn't mark you wrong if it didn't.
Had that,
It's-
cross it out.
Yeah, it's the same thing. It's like, the difference here is, remember when we talk about, this is a little tiny QRS, and one of the criteria for a pathologic Q is greater than 25% of the total QRS.
Yeah,
And
definitely is.
that one. So it's actually 2 of them. The other thing is, for this size QRS, this is an enormous Q. So I suspect there could be an old inferior, but it's like, I wouldn't bet more than $2. So, I mean, that's about how the importance I give it, yeah,
Okay.
so.
It looks like proportionately, there's maybe a little bit of depression in one in ABL. Would
Uh-huh.
that also be a sign of an old one, or?
No, it would be a sign of something happening now.
Okay.
Okay, but there's certainly not enough. I will mention to you, this is the second one that it's come up in. Something that we're going to learn in 2 weeks is that something to be suspicious of is when the first part of the ST segment and the T wave sort of straighten out, which it's hard to see because it's so small. So I'm seeing that, and I'm seeing this, and it would be really interesting to see this one. If it is, it could easily be an inferior STEMI that's progressive. So, but I don't think, if so, I still think the Q waves are probably old, because there's not good ST elevation there. Okay. Who's next?
I think that's me.
Okay.
So I had ST elevation in 2, 3, and AVF, and then also in B5 and B6. And for evidence of the inferior STEMI was the reciprocal changes in ABL.
Good. Okay.
I didn't see any signs of the old infarctions, but I would check for right-sided.
Yeah, absolutely. So I'm sorry. So let me. I was just a little spaced out there for a minute. So inferior,
Yep.
lateral. Anything else? And check for right-sided. I like that.
I don't really know what the rhythm is, but
Anybody know what the rhythm is?
it's a Brady rhythm.
Oh, say it again.
I just looked on it.
Oh, you just looked.
Yeah,
Okay.
it's pretty cute.
Yeah, if you looked, it said I cheated, so you could cheat too. So, yeah.
I'm struggling reading the rhythms for these, like, so how, can you explain how I would do it, or where I look
Well,
at lead two
the real
lines?
question is, why would you do it? So, here's the deal, is that I think that having to read the rhythm from a 12 lead with no rhythm strip is silly, even though I'm making you do it, okay? And because it's hard to do. If it's, normal sinus, we can do that, and AFib, you can do that. But you only have 2.5 seconds, and that's what can be hard on it. And so the only reason I'm asking you to do it is I know there were years in the National Registry in the dynamic cardiac where they were expecting people to do that. And like I say, I think it's stupid, because as a paramedic, you do a rhythm strip first, and that's what you use. In the hospital, you run rhythm strips off the bottom, and that's what you use. So that's really the only reason why I'm asking you to do it. If you can't do it, I'm not too worked up about it.
So you go off a lead two, correct?
Well, any lead that's helpful to you, right? So the thing to really check out is regularity you can do, because even though it changes shape, it's really 1 10-second rhythm strip. So you can take your calipers and check regularity. So actually AFib is one of the easier ones to pick up on a 12 lead, because you can see if it's regular or irregular. If it's regular, then what I would do is start looking for P waves. And once you have them, and you can see the P waves here, and you confirm it by looking at some of the other leaves. Oh yeah, there's P waves here. Then it's normal sinus. Okay. The only thing that really throws this one off is this. And it's really weird. So what I did was I went back to which you couldn't do because I didn't give it to you. I went back to the reference and looked. They had a rhythm strip along the bottom, and looked, and it is one premature beat. It does have a P wave, so it's a PAC.
Okay.
And that's how I figured it out. So there's another one, and I can't remember if it's in here or in the extra STEMI homework, that's a 3rd degree AV block, which was almost impossible to figure out. So that's my reasoning for asking you to do it. But if you can't do it, it's really because it's hard to do and kind of silly, because you need more than 2.5 seconds. Okay? Okay, anything else here? Oh, I don't think you caught this, Andrew, and I think it's reasonable. I think it's reasonable to get. I think if you didn't get it on the test, I would mark it wrong, is the possible posterior. Because there is an inferior, and if you look, that's actually ST,
yeah, well,
yeah.
no one would
And I know
know
you
now.
just, you're
Yeah.
just learning it, so no big deal.
Okay.
But I want you to get it now. That's why I did that part of the lecture before we went through, so we could pick up all those.
Okay.
Yeah. Okay. Any questions? Okay, next one.
Alright.
So, I see ST elevations in 1, I see depression, or 1 in ABL,
Good.
I see depression in 2, 3 in ABF, so reciprocal changes. I see ST elevation in 1, 2, and 3.
You mean V1, V2, V3?
Yeah, sorry,
Uh-huh.
V1, V2, and V3.
Good.
So, going from saying it correctly, I see septal V1, V2,
Uh-huh.
ST elevation, and then are those pathological cues on
Yes, they are.
Okay, cool.
V1 and V2. Yes.
Anterior, so V3,
Uh-huh.
and then, like I said, 1 in ABL has SD elevation with reciprocal changes, so 2, 3, 4.
So what kind of STEMI is that? One in AVL.
1 in ABL is lateral.
Good. Okay. Okay, so that's great.
The whole thing would be septal, anterior, lateral, right?
Perfect. Perfect. So what is the rhythm? I think this one you can pretty
This is
easy.
what is that.
Yeah. And are there any signs of old infarctions?
Yes, because the pathological cues,
In where?
2 and 3.
V2 and V3? So in this
One,
particular
two.
case, so here's the thing, is pathological cues are a little bit slippery.
Right.
If they are with some acute ST elevation that's happening now, we think of them as part of what's happening now. It simply means that the infarction has progressed 2 to 3 hours and the Q waves could have developed. If you saw these Q waves in V1 and V2 and there was no ST elevation, no anterior STEMI, no septal STEMI, then you would say, oh, it's probably because it's old, because they hang out, they stay around forever. So in this case, there are pathological cues, but they're not they're associated with acute stuff, the ST elevation, so they're not old stuff. Does that make sense?
Yeah.
Okay. Okay, and then check for right-sided no. Okay, good job. Okay. Okay,
Alright.
all yours.
So for 9, infarct area, I had ST elevation in 2, 3, and AVF,
Mm-hmm.
with reciprocal changes in ABF. I also had ST elevation in V3 and V4,
Okay.
and then and also in V5 and V6. Well, maybe V6, kind of in V6.
Okay.
Actually, it's a lot more easy to see under end.
Okay. So what are you ending up with? Give me the final answer here.
I have the infarct areas inferior, anterior, and lateral.
Okay.
And then normal sinus rhythm, no signs of old infarctions, and I would check for the right side.
Okay. And I think you said it, but just say it again. Additional evidence for the inferior.
Reciprocal changes in ABL.
Good. Okay, so we're sort of in agreement. I would have marked you correct. We're actually in slight disagreement, but I would have marked you correct. Because, so first of all, the inferior, absolutely, and we're back in the same old thing. Yes, there is a pathologic cue in lead 3, but just lead 3, it's by itself on this, it could be a normal variant, okay? So we're not gonna count that. I agree with you on V3. You have to be careful on V3. Remember V2 and V3 are those ones where you need extra elevation, okay? And it could be there, it's about 1.5, so, but it's a little borderline whether that counts or not, okay? And then, it could be in V4. So again, for me, I don't think it's there, but I won't mark you wrong. That's exactly what that means when I put it in parentheses. I'm okay if you see it, I'm okay if you don't. Same thing with V5 and V6. I don't think there's quite enough elevation there. But I think all of these leads are kind of suspicious looking, and I want to keep my eye on them. So,
Especially with like there being like a legitimate 1 and 2, 3 in AVF, wouldn't that kind of raise some red flags? Like you already have a definite elevation in 2, 3 in AVF if you're also seeing it.
well, maybe.
in V3.
I mean, you have to say, not necessarily, what's the most commonly involved arteries for an inferior STEMI? I'll help you out, because I know. So, but that is an issue, so you have to say, well, it's either the RCA or the LCF, so the right coronary artery or left circumflex. And the most commonly involved artery for these is the left anterior descending. So they're not necessarily related. So, okay. So next one.
Okay, I said, there's an interior, and 2, 3, and AVF, elevation there, and then, lateral in G5 and G6. And, there's also some ST depression in V1 and V2.
And now that you know, what does that mean to you?
Check for possible posterior.
Okay.
And then it's sinus tack,
Mm-hmm.
and I don't see any signs of old infarctions, and I would check for the right-sided.
Good. Oops, sorry, wrong way. Okay, so inferior, and there really is no other evidence. It's just the ST elevation. Anterior, V4, V5, V6 are your contiguous leads, of which 2 are in the lateral region and 1 in the anterior region. There's also a possible posterior ST depression V1, V2, large R in V2. Okay? Okay, let's move along. Next one, please.
I said the infarct area was lateral with elevation in 1 and AVL.
Okay.
Septal with maybe a box in V1, but definite elevation in V2.
Okay.
And anterior with elevation in 3 and 4. For the lateral extra evidence, there's reciprocal changes in 2, 3 AVF. I think I noticed, or maybe some Qs in V2.
Uh-huh.
I thought this might have been a first degree heart block too.
I agree with you.
And I wouldn't check for a right-sided.
Okay. So pretty much totally in agreement. I agree with you about V1. It's a little bit ambiguous. So okay if you have it, okay if you don't. There's one thing. Oh, I included, so Q's in V1 and V2. The reason I included V3 is, even though it doesn't quite, it actually might meet the criterion for pathologic Q's, because it's wider than, or at least one small box at the top. But also, it's in conjunct, you see how it's V1, V2, V3?
Mm-hmm.
And usually when you see something like Q's, you'll have one that's the main one, and then they kind of spill off on either side. So I included it. I wouldn't get too worked up if you didn't include it, because it doesn't quite meet criteria, but that's why I did. Yeah.
When I read that last, I was having a hard time telling if those were P's
Uh-huh.
or U waves.
So a good way to check that out is, again, look at all of the different, so first of all, not always, but most of the time, T's and U's are, if one's upright, the other one's, they're both either,
Okay.
okay? But also look at V1. So I think it's pretty fair, to say, nah, that doesn't, it's a little bit too far off to think of a U wave. So it makes more sense it's a P wave. So, okay.
Can you, the first degree AVB, I have absolutely no idea how you figured that out.
Well, you find the P waves. Actually, 3 is a really good one for the P waves, and you measure the PR interval from here to here, and it's greater than 5 small
It was
boxes.
just, okay, yeah, they're just lengthening, that's what it's based on, okay.
So, first degree AV block has a PR interval greater than 5 small boxes. Okay, moving along. I'm sort of pushing us because we have to do the cardiac axis today, so we'll get this done. Okay, who's next?
It's me, sorry.
Okay.
Okay, we have SD elevation in 2-3 and ABF, inferior, and it looks like maybe some simple changes in 1 in EVL.
Good.
Let's see, and then, now that I know it, it looks like there's some depression in 1 and 2, B1 and 2.
Good.
Sorry, which would imply potential posterior MI.
Good. Excellent.
Let's see.
So I'm going to jump over some questions again. I really want to make sure we get the cardiac axis done.
Sure.
So I'm going to talk about the rhythm in a minute because this one's almost impossible. Are there any signs of old infarctions? There are no pathological cues, but Riley, would you check for a right-sided?
Yes.
Why? Oh, yes, you're correct. Yes, absolutely correct. This is a 3rd degree AV block, and the only way I got this, I'm pretty sure it is, I'm like 90% sure it is I looked at it and went, oh, what is this? And printed it out and really sat there with calipers. And the way I was able to figure it out was to look at 1 and AVR. And if anybody wants to know, the P waves were here, let's see, where was it? It was here, the little divot there, here, and you can see they moved. And after that, it got really confusing, but I'm pretty sure it's a 3rd degree AV block. I don't, it took me a long time, printed out with calipers, and it makes no sense to use a 12 lead for that, but that's what it is. So if you didn't get that one, it makes sense you didn't get it. Okay, moving along. Next one, please.
13, normal sinus rhythm, nothing remarkable,
No. Okay, good. Okay, next one.
I said sinus talk with a PVC.
Good.
Looking at it, there's a possible, looking at the Q's in AVF and maybe in 3.
I agree with that.
Agrees.
Yep.
Maybe possible, but we're not, we're old.
Yeah, in this particular case, so sinus tach, you're correct, the PVC, I don't have it here. In this case, even though we keep saying, oh, normal variant, this is a huge Q wave. It's bigger than the R wave, it's wide, it's huge. And also it's an association with that one. So I think it's reasonable to say there's an old inferior STEMI here. But nothing acute. And then I think this is the last one. Okay, Natalie.
I said elevation in AVL, and I saw depression in AVF and 3,
Okay.
and maybe a little bit of elevation in 1 as well, so it'd be inferior MI, reciprocal changes. No.
Wait, say it again? So where's the elevation and where's the reciprocal changes? You got it mixed up.
Elevations in 1 in AVL,
Okay.
and then depressions in 3 in AVF, so it's a lateral with the reciprocal changes.
Okay.
So,
Yes.
Yeah,
yeah, we're gonna stop there. Okay, so, any questions? Are people feeling pretty comfortable with this? I've got, we definitely are not gonna get to it. I'm always thinking, oh, we'll have so much extra time. We're not gonna get to it today, but there is another practice. I've got them printed out. You can do it at home. The answers are there. Contact me with questions. Let's do a quick break of, oh, we've got an hour and a half, so we're good. Okay, so let's take a 10-minute break, and then when we come back, we'll jump into cardiac access.